So today we will discuss the topics, the drug on the Eribulin Mesylate. It's used in the treatment of patients with HER2 negative and triple breast cancers. So next slide, please. If you look at the history of the Eribulin Mesylate, the tag name is halaven. Halaven is a structurally simplified synthetic analog of helichondrin B. This helichondrin B is a natural murine sponge product. This halaven is a non-taxane microtubule dynamics inhibitors. It is approved by the US FDA on 15 November 2010 after a long research, nearly 25 years of struggle of research in the laboratory. Then it is approved by the US FDA. We know we have three microtubule inhibitors. One is halaven, other is vinblastine, and another one is taxanes. Next slide, please. So if we look at the mode of action of the halaven, it binds. If you look at on the left side, this is the microtubule. This is the plus and this is the negative end. This halaven binds at the top of the microtubule and the positive ends. Then it stops the microtubule lengthening. Ultimately, it acts as a microtubule inhibitor. Next slide. But vinblastine, it binds at the sides of the microtubule and disrupts the structures. So it stops the microtubule shortening and lengthening. Next slide, please. And our taxane binds to the beta subunit of the cells and acts by stopping the microtubule lengthening and shortening by binding instead of locally. Ultimately, it inhibits the microtubules. Next slide. We know any sorts of cancers, any types of cancers metastasize. So there is a step how the metastasis occurs. So epithelial to mesenchymal, there is a epithelial to mesenchymal transitions. There is cellular polarity to non-cellular polarity, cellulation to loss of cellulation, stationary to high E cathepsin, high E cathepsin to low cathepsin. So this process, which is EMT, epithelial to mesenchymal transition, this causes the metastasis of the most of the cancers. Next slide. But halaven stops the epithelial to mesenchymal transition of tumors by improving the hypoxia. We know hypoxia is very important for the metastasis. So halaven works by basically to dual action. First of all, it causes the irreversible mitotic blockage, thus causes apoptosis and death of tumor cells. Another its action is it induces vascular remodeling to improve hypoxia status of the tumor, reverses the tumor cell to epithelial phenotype, reduces migratory and invasive capacity of tumor cells. Two-way action. One way is irreversible mitotic blockage, another is induces vascular remodeling. So improve the hypoxia status. On this background of this mode of actions, the halaven is the only single agent drug to improve the overall survival in two indications. Here, halaven is approved in two indications, metastatic breast cancers and soft tissue sarcoma. In the two actions, if you look at the metastatic breast cancers in the halaven group and in the control arm, briefly in the halaven group in the metastatic breast cancers, after two prior therapies, it causes 13.2 months, that is median overall survival. Whereas control arm, that is treatment of physician choice, 10.6 months. On the other way, advanced liposarcoma, 15.6 months in the halaven groups and 8.4 months the groups which containing the dicarbazine. On this result, on the basis of the results, then these drugs is approved in the two indications, especially in the metastatic breast cancers and advanced liposarcoma. So today's topic is our place of eribulin in the HER2 negative and triple negative metastatic breast cancers. There is a landmark study, the EMBRACE study, eribulin monotherapy versus treatment of physician choice in patients with metastatic breast cancer. There is a phase 3 open-label randomized study, study 305. In this study, it is a phase 3 study, multi-center, randomized open-label study, eribulin versus treatment of physician choice in the pretreated locally or recurrent metastatic breast cancers. The key inclusion criteria were, the first of all, age 18 years older, histology or cytology proven that it is metastatic cancers. Then it is received 2 to 5 cycles of previous chemotherapy. This chemotherapy definitely includes the anthracycline taxanes and 2 or more other regimens for locally recurrent breast cancers. Progression within 6 months or less of latest chemotherapy, definitely adequate bone marrow, liver, and renal functions. This is the trial design. In the one arm, Eribulin Mesylate, number of patients was 508, and the treatment of patient choice number 254. That is 2:1 protocol. Eribulin was used in the 1.4 mg per meter square IV over 2 to 5 minutes on day 1 and day 8, 21 days intervals. And the treatment of patient choice, any monotherapy, any psychiatric drugs, any hormonal therapy, any biological therapy, any radiotherapy. So our intention to see the primary endpoint, that is overall survival. Secondary endpoint was progressive survival, over response rate, and safety profile. In the treatment of patient choice, these drugs are generally used. Bilirubin, it was the number of patients was 61, gemcitabine 46, capecitabine 44, taxanes 38, anthracycline 24, other chemotherapy 25, hormonal 9. Total patient was 247. These drugs were used as a chemotherapy, the treatment of patient choice. If you look at this cartoon, in this graph, we see here in the Eribulin group, it is 1 year survival is 53.9%, and treatment of patient choice it is 43%. And Eribulin groups, it is better than the treatment of patient choice. In the patient choice, it is 10.6. It is more than 15. Next slide, please. It was also validated by the regulatory authority. It shows the better result, the same result, more or less same results in the Eribulin group is better than treatment of patient choice. So on this basis of the EMBRACE trial results, this drug is approved by the US FDA. It's a large randomized multicenter trial, showed consistent result across most patient subsets. Study design 305 exhibited many of their desirable characteristics. Efficacy, that is primary analysis and update analysis, shows the better efficacy. A safety profile, adverse reaction observed in the Eribulin patients were typical of those that occur with other microtubule independent drugs such as bean calculators and taxanes. And these all side effects are easily manageable. So on this basis, if we conclude this trial, Eribulin is the first and only monotherapy to demonstrate the improvement in overall survival in women-treated metastatic breast cancers. It improves the overall survival in the EMBRACE study. In the EMBRACE study, Eribulin demonstrated manageable toxicity profile, and adverse effects were those commonly associated with other chemotherapy agents. Usually, neutropenia is the most common hematological effects, but a rare case of incidence of febrile neutropenia is less. And incidence of grade 3 and 4 neuropathy was compatible with patients with or without pre-existing neuropathy. So in another study, phase 3, open label, randomized, multicenter study number 301 of Eribulin Mesylate versus capecitabine in patients with locally advanced or metastatic breast cancer previously treated with anthracycline and taxanes. In this phase 3 trial, the 301 design, that is eligibility criteria was, the number of patients was more than 1,000. Eligibility locally advanced or metastatic breast cancers, 3 or less than 3 prior chemotherapy regimens, prior taxanes or plus regimens. One group Eribulin 1.4 per meter square, IV infusion, short infusion, day 1, day 8, 21 days intervals. Another group capecitabine, it is 1250 milligram per meter square, 2 times daily orally, day 1 to day 14. 21 days intervals. The more two primary endpoints was overall survival. Secondary endpoints includes quality of life, overall response rates, duration of response rates, and safety profiles. So if we look at this subgroup analysis, Eribulin is better than capecitabine in a specific group of patients. If it is HER2 negative, that is 15.9 months and 13.5 months overall survival. 15.9 months overall survival Eribulin group, 13.5 months the capecitabine groups. In the ER negative, negative patients, 14.4 months in the Eribulin groups overall survival, median overall survivals, and 10.5 months overall survival in the capsulotomy arms. In the triple negative patients, it is 14.4 months in the eribulin group overall survival and 9.4 months in the capsulotomy groups. So if we analyze this the trial, so it is eribulin is better in the case of HER2 negative, ER negative, triple-negative cases than capsulotomies. If you look at these adverse events in the eribulin group and capsulotomy groups, neutropenia is more common than capsulotomy groups. Leukopenia also more common, but in the capsulotomy groups, that is more hand-foot syndromes and more diarrhea. So in this study, the author concludes in this way: the trial did not demonstrate the statistically significant superior result than capsulotomies in either overall survival or potential survival, as the median overall survival is 50.9 months eribulin group, 14.5 months capsulotomy arms. But if we analyze the group in a triple-negative breast cancers, it is ER negative breast cancers, HER2 breast cancers, it is better than the capsulotomy groups. Toxicity profiles eribulin and capsulotomy were consistent with the previously known side effects and easily manageable. So in this pre-specified subgroup analysis from a phase 3 open-label randomized study, that is 301, this study of eribulin mesylate versus capsulotomy in pretreated patients with advanced metastatic breast cancers. Halaven significantly improved the overall survival versus capsulotomy in the triple-negative breast cancers more than 5 months. So in the triple-negative breast cancers, if we use halaven in the second line, in the second or third line, so it gives the more benefit, 5 months benefit than the capsulotomy arms. Definitely significantly improved the overall survival than capsulotomy in the HER2 negative patients also, 2.4 months. So if in this slide, patients with advanced metastatic breast cancers, HER2 negative, ER negative, or triple-negative patients may gain particular benefit. So efficacy of eribulin in women with metastatic breast cancer, the pooled analysis of the two phase 3 studies, these two studies, if we analyze, that is one study 301 as 305, one group eribulin and with versus capsulotomy, another group eribulin versus treatment of fistula. These both groups, it shows the more benefit in favor of eribulin group than treatment of fistula trends and the treatment of capsulotomies. So in the overall survival in the intent to treat the populations in these two groups, the 305 study and 301 study, there is treatment of fistula trends and capsulotomy groups. In altogether, eribulin gives them overall median survival, 15.2 months, whereas control group there is 12.8 months. So significant difference in the median overall survival in favor of eribulin or control treatment was seen in most subgroup assessment. Women with HER2 negative disease gained a significant survival benefit from eribulin, and the benefit was also found regardless of triple negative status. So in these conclusions, the patients with HER2 negative breast cancers, about 85% women with metastatic breast cancer, a pool analysis confirmed that these women benefit significantly from eribulin is a particular clinical relevance. Women with triple negative breast cancer may derive a particular strong benefit from eribulin. So the real world evidence in triple negative breast cancers, the new study confirms the robust efficacy of the eribulin in triple negative breast cancers. It is published in the Willis Cancer Medicine. The clinical benefit of treatment with eribulin mesylate for metastatic triple negative breast cancers, a long-term outcomes of patients treated in the US community oncology settings. Outcomes of the metastatic triple negative breast cancer patients treated eribulin mesylate at community oncology practice in the United States. It is, we know that triple negative breast cancer accounts 50-20% of breast cancers. HER2 positive and HER2 positive, HR positive and HER2 positive patients about 50, average survival exceed 50 months. Survival of metastasis is considered in the metastatic triple negative breast cancer considered shorter, ranging from 11 to 17.8 months. So sequential chemotherapy remains the mainstay of treatment for patients with triple negative breast cancers. So this is the first respectively large community-based study of eribulin triple negative breast cancers. As triple negative breast cancer defined here, ER less than 1%, PR less than 1%, HER2 negative, according to the current ASCO and College of American Pathology guidelines. Biopsy proven triple negative breast cancers. So physician identified the ministry treatment of breast cancers. This study was performed in 1st January 2011 to 1st January 2014. And Eribulin treatment in the metastatic setting was categorized as the early use, that is first or second line, late use, third line, or the later lines. It shows the overall survival, disease response, and adverse events. So this group shows the use of Eribulin in the early stage, that is early line of chemotherapy, first or second line, after first or second line chemotherapy, and also late Eribulin users, that is low after more than 3 line of chemotherapy, 4 line of chemotherapy, and it shows different number of patients in the different stages of the breast cancers. It shows the different metastatic sites, bone, liver, lymph nodes, lung, brain, other sites in these different early uses and late uses. It shows the different metastatic sites. So in this early cohort, Eribulin used first or second line, and the late cohort, Eribulin used in the third line and lateral line. Endpoint was response rate, that is complete response, partial response, or survival. This shows the different line of treatment. Next slide. So if you look at the results in the early users, that is after first or second line chemotherapy, if we use the Eribulin, the response rate is 69.9%, 23 months of median survival. In the late users, that is third or fourth line chemotherapy, after third or fourth line chemotherapy, response rate 48.8% and median 14.7 months. So median overall survival, all patients 70.6 months. There is another study, that is observational study of the clinical outcome of Eribulin Mesylate in the metastatic breast cancers after CDK4/6 inhibitor therapy. Its objective was evaluation, efficacy, and safety for patients receiving Eribulin Mesylate after previous treatment with any CDK4 inhibitor. Number of patients was 395. So CDK4/6 inhibitor is the treatment is used in the breast cancers. It has not eliminated the need for chemotherapy, but analysis of the recent treatment pattern post CDK4/6 inhibitor found 35.6% of regimens immediately following discontinuation of the first line CD4 and 6 inhibitor therapy were chemotherapy. So to determine the overall response rate, diameter of all the lesions were assessed, date of scan also assessed, RECIST criteria also says that is complete response, partial response, stable disease, approximate disease. So use of halaben in the post CDK4 inhibitors evaluated in the following lines. In the second line, after use of CDK4 inhibitor Eribulin, third line CDK4/6 inhibitor, then any other treatment, then Eribulin. The fourth line CDK4/6 inhibitor, then anthracycline, taxane, then other chemotherapy, then Eribulin. After fourth line, that CDK4 inhibitor, any treatment, Eribulin. So these after first line, second line, third line, fourth line, different lines, the Eribulin is used after the CDK4 inhibitors. So after second line, it shows the overall response rate is 42.2%, clinical benefit that is 58.7%. But more line users show response rate less. After fourth line is 26.7% and 54.1% in the clinical benefit. So overall, it observed that Eribulin appears well tolerated with few treatment-related discontinuation observed in the study, and to provide a clinical benefit which was not less than that observed in the pivotal trial when used at the diverse potential in the treatment pathway. In the NCCN guidelines, that is, and in the advanced metastatic settings, the drugs are used: liposomal doxorubicin, capecitabine, vinorelbine, gemcitabine, Eribulin. But Eribulin shows that it is a very effective, pure unlikely, but sometimes provides long-term survival advantage. In the ESCO recommendations for chemotherapy, for chemotherapy targeted therapy for women with HER2 negative metastatic breast cancers, the most convincing data are for Eribulin based on survival superiority against best standard treatment in a recent large randomized trial. But there is a lack of good comparative data between these various agents. This was the comment of the recommendation of the ESCO. This halaben article was published in the JSU journal, also in the poster presentations in the ESCO meeting. So it is approved after second line of metastatic breast cancers. That is, it is indicated for the treatment of adult patients with advanced metastatic breast cancer who have progressed after one chemotherapy regimen for advanced disease. Prior therapy should be included anthracycline and taxane in either the adjuvant, breast settings unless patients are stable for these treatments. So dose schedule was dose 1.4 mg per meter square. Infusion time, it is used with 100 ml of normal saline, not used in dextrose. 2.5 minutes short infusions. Schedule was day 1 and day 8, 2 days interval, and continued up to the disease progression or intolerable toxicity. So it is used with caution in the hepatic impairment cases. If it is used in the mild, moderate, severe, then those definitely reduce doses. So in the end, I again thanks all the participants for their patient sharing. This slide actually provided by the Radiant Pharmaceuticals and prepared by the ESI company. So this is their actual presentations. This is not my own slide. So thank you all.